This video examines the Mental Health Care Act, India's ambitious blueprint for transforming mental health care. It represents a paradigm shift from a system based on custodial confinement to one based on human rights and dignity. The 1987 Mental Health Act used a custodial model, viewing patients as a danger to society and often resulted in inhumane treatment. The 2017 MHCA, however, views mental illness as a health issue, prioritizing individual dignity and rights-based care. The new law strictly defines mental illness based on international standards, distinct from the legal concept of, quote, unsoundness of mind. Crucially, Section 18 establishes mental health care as a legally enforceable statutory right, not a privilege. Section 20 upholds human dignity as a non-negotiable standard. This includes a total ban on chaining, prohibition of forced tonsuring, and guaranteed rights to privacy, wholesome food, and protection from all forms of abuse. The Advance Directive, or Ulysses contract, allows a person with capacity to dictate their future care, ensuring autonomy even during periods of incapacity. Medical professionals must legally follow these written instructions. The Act includes specialized protections for vulnerable populations. This includes strict rules against separating mothers from infants and an absolute ban on electroconvulsive therapy for minors. ECT for all patients requires muscle relaxants and anesthesia. The MHCA extends legal shields to marginalized populations. Section 115 decriminalizes attempted suicide, treating it as a sign of severe stress. Section 103 mandates psychiatric wards in prisons and authorizes transfers to dedicated mental health facilities. The MHCA 2017 establishes a gold standard legislative blueprint focused on 4 pillars: agency, dignity, accessibility, and destigmatization. On paper, it is globally recognized as a legally flawless framework. However, the blueprint faces severe structural deficits. Only 1.3% of the healthcare budget is allocated to mental health, resulting in an unfunded mandate. This contributes to a staggering 90% treatment gap and a severe shortage of psychiatrists. The reality on the ground is grim. A National Human Rights Commission verdict described all government mental health care institutions as providing, quote, pathetic and inhuman handling. State review boards often remain non-functional, hindering grievance redressal. A friction matrix highlights the gap between the law's text and reality. Out-of-pocket costs undermine the right to free care. Illiteracy and poor formatting make advance directives unusable for rural populations. Under-resourced providers are subject to severe red tape. Reform must begin with 2 critical phases. Phase 1 requires a drastic increase in financial commitment to fund the law. Phase 2 involves aggressive funding for infrastructure and halfway homes to end the illegal detention of cured patients. Phase 3 calls for comprehensive sensitization of police and judiciary to ensure the decriminalization of suicide is actually implemented. Phase 4 mandates the formal integration and support of family caregivers, who currently manage 90% of the care budget. The MHCA 2017 is a legal triumph, but a law without resources is merely a suggestion. The state must shift its focus from legal compliance to proactive capacity building across finance, infrastructure, sensitization, and caregiver support. The philosophical shift from custodial confinement to rights-based care is complete on paper. It is now the urgent mandate of government and society to ensure the dignity promised by the Mental Health Care Act becomes the lived reality of every citizen. Thank you for watching this video. Please remember to like, comment, and subscribe to Dr. Amaravati H. Insights for more science, research, and analysis.